That's why the pediatric cardiology session today also we wanted to have the best. And we are fortunate that Dr. Krishna Kumar sir and Dr. Shiv Kumar and Dr. Jay Ranganath, Dr. Sunita Madam, Dr. Dr. Bharat Dalvi also is supposed to join, and we have Dr. Kavita, Sweta, others joining. Thank you all for joining and encouraging us. And with this few words, I now request Dr. Krishna Kumar sir, and I think Shiv Kumar will also join to take over and conduct this session. And the other panelists, some of them already joined. Dr. Kavita, Sweta is doing case along with Nageshwar Rao. Dr. Sudeep will join. With this, over to you, Dr. Krishna Kumar sir.
So it's always very wonderful to be a part of this extremely ambitious venture, where we are having catheter interventions being discussed with very large global audience. And I think the virtual platform really allows actually more reach, as well as in some ways greater flexibility with the process, and of course the convenience of not having to travel. So I am all for it actually, and wonderful to be here. So we can, I think the first speaker is Dr. Jay Ranganath.
Yes, sir.
You can actually introduce the topic because I'm not able to see the program.
Yeah. He will be speaking on congenital coronary AV fistula closure techniques with case examples. As we mostly predominantly, as you understand, a lot of adult cardiologists get involved in it. Sometimes we also tend to get. So we thought some of these topics will be apt for keeping the adults also in view. So this Dr. Jay Ranganath is again, as we know, professor of cardiology in Jayadeva Hospital, Bangalore, which is a very active center. And he'll be sharing his experience of this technique with all of us. Over to you, Dr. Jay Ranganath.
Thank you, Dr. Srinivas Kumar. Thanks for inviting me. So a brief introduction about this particular condition. It's a rare congenital anomalous communications that may be a single or multiple and occur between one or more coronary arteries. Usually they are solitary and a cardiac chamber. It most frequently arises according to the literature from the right coronary system, but I think it might vary according to the various series. Lot do originate from the left side or bilaterally, very rarely. Most cases of fistula are asymptomatic, detected incidentally. This is extremely important. There is no consensus on the management of the symptomatic fistula because the rarity, surgical repair used to be the standard form of treatment. Catheter closure is the thing now in last probably a decade or so, more than that, 15 years, 20 years. Medical management have been successfully tried. Medical management in asymptomatic, not much of hemodynamically significant fistula is still an option. I don't think we need to put every child who has got this kind of fistula into the procedure. Then what are the complications or sequelae can happen because of this fistula? Aneurysm formation very rarely. Infective endocarditis once again rare. Congestive cardiac failure, if it is a large shunt in a child, we do come across with a congestive heart failure, tachyarrhythmias occasional. So when to close? This is the thing which we need to, all of us have to understand. Not just because we find some fistula at the age of 3 months or 6 months does not mean that we need to go inside and close it. At the same time, if you have a fistula, an elderly person, a 40, 55-year-old man with a very insignificant fistula, just because it is there, you don't have to close it. So hemodynamically significant fistula with significant shunt and volume overload of any of the chambers, both right and left chambers. And very rarely, a myocardial ischemia, if you can prove that there is ischemia induced by this fistula and congestive heart failure. So prerequisites. Of course, we know that we do diagnose on the echocardiogram after having suspecting on the clinically you cannot make a diagnosis of a fistula, though it can give us a clue. But echo is the most important standard form of imaging. The CT is a must before planning any of these fistula closures. MRI, some people do undertake the MRI. Other information like flows and shunt, everything, and coronary angiogram or a conventional angiogram. Coronary angiogram, we need to do the conventional angiogram. Balloon occlusion angiogram just before the procedure, or I mean, it can be done at the same time when you're planning the fistula. This many times, if the CT is not done for some reason, or if you've done the CT to have a proper understanding of the origin of the branches of the coronary arteries, this is extremely important. Also, it gives a lot of clue about the closest differential diagnosis for this is the tunnels. The fistula are different, and the aorta to LV or RV or the tunnels are different. The histopathologically, absolutely, they are different. But how to image, how to differentiate and distinguish is also very important. So balloon occlusion angiogram gives us a lot of importance. The hardware, this is a must. Unless you have the proper hardware on your cath lab shelf, I don't think you should undertake any of this fistula, because we are meddling in the coronary arteries and the aorta. So the routine catheters, like diagnostic catheters, are various types. You need, many times you need a Judkins Wright, thermo catheters, glide catheters, a lot of catheters. You can work on any of these catheters which are comfortable. The most important catheters, what we use, the Judkins Wright and a multi-purpose these catheters. So you should have the glide catheters on the table. That's a soft catheters. The guide catheters of various 5F to 8F. 8F is not easily available in majority of the cath labs, but it comes to our rescue at times. The guide wires, the workhorse for children closing of fistula, even today, is our guide wire, hydrophilic guide wires, the coronary guide wires, and various. You should have all kinds of guide wires. O8, O32, O35, along with the Teflon thermo guide wires, you should have on the table the extra stiff wires in adult patients. The braided sheath, this is the most important. When you're using a sheath in the closure of the fistula, just don't use the routine sheaths, which are Mullen sheaths, blue color sheaths, but use, because there's a lot of curvature it has to take, the braided sheaths are a must or mandatory before embarking upon these closures. Devices, any device is okay, but the standard devices, what we use nowadays is amplified vascular plug, the ADO, the amplified ductal occluders, or the similar types. The VSD devices, MFO, multifunctional devices, or the Conar device. Coils have still got a place. We have closed a lot of in our setting also, a lot of coils have been used. The approach to closure, after making the diagnosis, the indication is right, so you have decided to close. Then you have to planning is important. You have done a lot of imaging, you have know the sizing of the, where exactly what kind of the device you need to use, what size of device, all these things you should have pre-planned, because you should not try to do all that on the table. Many times, of course, the angiography will help you, but you should have taken enough care before that. So approach to closure, the various, these are the four which we have done: femoral arterial approach, venous approach, interjugular vein approach, axillary. So everything has got a place, and I'll give one or two, 4 or 5 examples. We'll discuss the examples of these approaches. So this is a 3-year-old boy, failure to thrive, echo was showing a fistula. So this is from the left sinus. You could see in the left main, it's predominantly in the area of the left anterior descending artery. We have done the CT, of course, we made sure that this fistula is opening into the RV apex. So this is the femoral approach. This is a guiding catheter. This was not a very difficult one. This is a straightforward one, not much of curvature. So we use the 6F guiding catheter, and we use this Conar device. This is a very, you can see the straight wire, no difficulty in engaging that fistula, passing the wire, passing the catheter, passing the, this is a guiding catheter, and putting a device is not very difficult. So it takes some time for the complete closure. So this is probably immediately after the procedure. So I think it's occluded more or less fine. So this is done through the femoral arterial approach. This is not the case in majority of the cases. Always, almost always, if it is opening to the right atrium, it is very easy to snare the wire and come through the femoral vein approach. But there are sometimes difficulty we face even to the femoral vein. There's another case which I'll tell you. 40-year-old female, hypertensive. So, there is a lot of symptomatic issues, like in dyspnea, continuous murmur, once again fistula. You see, this is the left sinus injection, the selective injection of the catheter, diagnostic catheter. This is from the left main, opening into the RA. So here the AV loop was formed. This we decided beforehand to close from the venous end, the femoral venous end. After snaring out, put the sheath into the fistula from the femoral vein, IVC, RA, and into the fistula. So this is, we have used here a muscular VST occluder. Probably we didn't have the proper size of the AVP, so we use, I think it works as good as any of the device. This is fairly simple. So what I want to tell you is that with the fistula is opening into the right atrium, this is fairly easy to snare it out from the femoral vein and the IVC and to the RA. So you can put a sheath on the venous end. So you don't have to put a very long sheath, large sheath to the arterial side, and you don't have to go meddle around with the ostium of the left main, the sinus, and the coronary arteries. So 54-year-old lady, similar fistula, LV dysfunction, you could see LV dilated and LV dysfunction. On the right hand side, you can see such a big fistula. You can see the CT angiogram, the narrowest part of the fistula. This is the EBU catheter. Unlike the previous fistula, zooming to the RA, here you can see a lot of circulations and undulations which is opening into the RA. This is one fistula, this kind of fistulas where you see the multiple irregularities, multiple circulations. It is not very easy to pass our regular thermovies, retaflanovies. Here you have to take the help of our coronary guide wires. You have to use many times. If the coronary wire, it is not very easy to snare this wire. So we used a microcatheter here. After this is, so we had some difficulty in getting, directing it towards the femoral vein. So we took the venous approach. Though we had taken the femoral venous approach, we took the intrajugular venous approach. So this is a braided sheath going there. Once you snare it out, the microcatheter was snared out, put a regular wire, then put it out. So this is very, very simple. This is an ambulance vascular plug, 18 mm, which was closed. Similar fistula, opening into the RA, but we use the intrajugular vein. So this is the final result of this fistula. So once again, one more, case 4 is a failed femoral artery approach. We use the axillary approach. So 18-month-old child, that is tachypnea and difficulty in feeding. This is LMCA to the RA. The small child, difficult to pass the, first of all, we don't want to use the arterial femoral artery, mess up the arterial access. So here a lot of difficulty using the microcatheter and all those things, spend some time. Then because of the curvature issue, once again, here we use the axillary approach, it becomes very easy. So this is one case where you use failed femoral artery approach, so use the axillary approach. So this is another case. This is not actually a fistula, this is the tunnel. You see the shunt, you see everything is going to the pulmonary artery. This is opening from the aorta to the RV tunnel. So once again, if it is opening to the RV, snaring and putting the sheath becomes a bit difficult. We tried that. It was a lot of splinting of the thing going on. So you see that curvature, it is not a very happy, not a very good, great curvature. If you get like this, is not very easy to put the sheath. So we immediately switch over to the axillary because we could have done this from the femoral artery. Child is only about 9.5 to 10 kilo. We didn't want to put a 7F sheath. So this was used axillary approach via 7F sheath. The conar device was used, 14 by 12. It becomes very easy. So this is basically to save the arterial access, one thing, and to ease of the procedure. Some residual shunt, but mostly okay. This is another very giant tunnel, once again, which we have showed you in multiple forums. From this aorta to the LV tunnel, we made sure that coronary is okay. So we attempted disclosure of from the femoral artery. Entering that fistula was not difficult, but orienting the device to put the device, a large device, was difficult. But let's negotiate. Once again, we switched over to the axillary. It was not very difficult. It's a muscular VST occluder. So post procedure of this, any of these fistulas, antiplatelets, we do start doing antiplatelets, anticoagulation, how long, rationale and duration, especially in a small child or an infant, you have done this. Also, how long to give, that's the issue, that's a controversial issue, that's a commonly asked question. The diuretics for some time till they do well, especially if there is a large fistula, AC inhibitors in elderly people, older people, and if there is ALV dysfunction. So how do you differentiate the fistula and tunnel? The CT angiogram will give us a lot of clue. Balloon occlusion angiography, selective coronary angiogram. Indication method is by and large do not vary in both. So I don't want to go into the detail of those things. Take home points: the multimodality imaging accurately delineating the anatomy, size, and course of the fistula and coronaries. Transcatheter closure will be successful if you use the right approach is chosen. Axillary approach is by and large we are using in our team is using if there is an issue of the axis or the curvature of the sheaths, a problem selectively many times we have started doing this. Patents of the negative coronary should be demonstrated post device closure in majority of the cases. Thank you very much.